Welcome to the World Lymphoedema Day, streaming out of Bayreuth, the headquarters of medi. My name is Nicholas Swark. This is Valerie's main event. We will guide you today through this wonderful set of interesting topics we prepared for you and which are live streaming around the world. Mm-hmm. We are present in 90 countries in the world, and we have very interesting topics all around scientific parts, and also patients will join us. Our goal is really to create awareness for the lymphedema across the globe. And I would like to hand over now to Valerie, and perhaps you can introduce yourself and guide us through.
Hello, everybody. We are so happy to have you here with us. The Lymphoedema Day today, 6th of March 2025, for us is really a day because we drive lymphedema awareness throughout the whole year. Today, the topics that we will be touching, we will be talking about secondary lymphedema after breast cancer. We will be talking about differences in primary lymphedema, how patients should be treated individually with according to their diagnosis. We will also, as you just mentioned, Nicolas, have a real patient here with us from the US that will talk about their personal experience, how they use compression, what they also wish both the scientific field as well as also other patients out there would do with their diagnosis and with their life, really. So we are happy to do this, and we are looking forward to the next topic that Nicolas is going to introduce.
Thank you very much, Valerie. Yeah, we're really excited to have the founder of the ILF, Professor Justine Moffatt. She has founded the ILF in 2009. She has dedicated her entire professional life towards the lymphedema, and it's we're very fortunate to have had the chance to talk to her. We had to record this meeting because she's very busy. She's traveling around the world for the sake of lymphedema, and we will talk to her about the vision and her ideas where the ILF, the International Lymphoedema Framework, will develop towards. Together with Brouwer, who is an expert in this field, we are very happy to have this interview now.
Welcome, everybody, to the World Lymphoedema Day, March 6th. We're very happy to have here today the chairperson of the ILF, the founder of the ILF, Professor Justine Moffatt. Thank you very much for your time.
Thank you for inviting me.
Of course, it's very nice to have you here. It's very nice because you were the founder of the ILF in 2009, if I could remember right. And since we have so many people on the line who are patients and physicians who would like to know a little bit more of your vision and for the future of the ILF.
Well, thank you very much. I think my passion for this began because I've always been a clinician. So I've always been working with people living with lymphedema. So that is the sort of backdrop for me, the underpinning principle. And I began to I work at St. George's Hospital in London in the early 2006. And we ran a big project that showed the reality of working in partnership to achieve major change in lymphedema. And in 2009, I created the International Lymphoedema Framework. Now, we're a registered charity, and it emerged because actually we were being contacted by many people across the world who were saying, we actually like the way that you're embracing partnership, that you're valuing people, and I suppose the underpinning principle of the ILF, which is the concept of belonging together. And believing that actually, lymphedema is a truly neglected disease. It really is neglected. And in the vision, the mission of ILF is to put lymphedema on the map. And within that is everything from communication, creating the evidence, working with the medical industry to build new innovations, which is why I'm delighted to be invited to participate in this. And so the idea of really working together to change the whole profile of lymphedema worldwide. And it's a global problem. So in high-income countries like UK, Germany, France, we're dealing with a different type of lymphedema to what you're dealing with in, say, Africa or India. But the suffering, the morbidity is the same. So that's that collective, that belonging together, which is really our motto.
Very nice. Thank you very much. We also have our dear colleague Els Brouwer on the line, who is our consultant, and she is worldwide connected to the world of lymphedema. And I'm happy that you also brought some questions along.
Thank you very much, Nico, for the invitation and being part of this fantastic interview. Hi, Christine. So what are your current projects of the ILF at the moment? Because you're doing a lot, I know, for years already. But what is the main goal of the projects you're doing right now?
Well, I suppose the overall goal of every project stream that we have is increasing access and building evidence. So we have a project called Lymprint, which is an international epidemiology project. And the reason for doing this was to just simply be able to show people how common this problem is and the impact it has on people, on families, and on society. We're really proud that we have this. We have 14 countries working with us now, a huge data set emerging, and that research has really begun to change policy in many countries. So we very strongly support not just synthesizing research, but growing our own research. Passionately concerned about education, and that's everything from working with patient organizations. We really value patients as, again, equals with us, and educating everybody from patients, clinicians, academics, and people working at policy level. So education is very strong. We have an Erasmus project where we're working with professionals dealing with children, right through to a big project in India where there's modules for treating lymphatic filariasis. And we do lots of research. We're passionate about compression research, for instance. We've done multinational studies together with our partners to be able to create evidence about things like compression therapy. And we also deal with more rare cases like children with lymphedema. We've got very strong children's streams. This is being supported by a number of our directors, particularly Isabelle Kerry from France. So we've got international children's camps. We are developing tools for measurement. We have quality of life tools. So we've actually got streams of work, but they are all culminating together in really building the profile. And the way we really do this is as well through our international conferences. So our international conferences are always in partnership with our national framework. So this year we're going to Canada, to Niagara Falls with the Canadian Lymphedema Framework. We bring all of our frameworks there, and it's a very dynamic experience. We have patient conferences during that. And we've got a very exciting initiative called the Compass Project that we are also working, very privileged to be working with you and with Nicholas, which is really building lymphedema in the APAC countries. That's terribly exciting. And we've got a big meeting in March, which is really about how do we take lymphedema forward in these countries through the concept of partnership together. So very exciting times.
Great. So yeah, you mentioned all these collaborations. We're going to do the Compass meeting indeed in the APAC region together, which is also for me an eye-opener to see that we can work together. Yeah, there are still gaps in lymphedema care, but also in lymphedema research. In some countries, it's really bad, as you know. How can we address those gaps?
Well, it's a big question, Else. I wish I could give you a simple. I think that the way ILF looks at things is to center these things on very much the national situation in countries. So ILF may be an umbrella organization. We have umbrella methodologies, but the individual countries have their individual issues, and you have to address it that way. And that will vary very differently across the world. And sometimes that might be addressing an issue of policy, it might be about raising particular research to be done in a country. So I think it really depends, but I think there is, in a way, there are common issues that span across the world. Industry have the issues around innovating in this space, the financial constraints that we're all facing across the world. So I think one of the principles ILF has is about its dynamic. So the world we're facing in lymphedema now is not the same world 20 years ago. So we have to think about CDT. What does it mean? Redefining it. The world is moving into self-management models. We have new technologies. We have AI. All of these things have to be thought through in order to look forward and not simply look backwards on, well, we've done this in the past, but to look forward.
Sounds like a very great aim. Back to Nico.
Thank you very much. We have one last question. Since we also have patients listening to this stream, what would you tell the patients for the future? How can the ILF can support their lives together with your partners?
Well, firstly, I would say that ILF is always engaged with patients, and I mean really engaged. So we never have any initiative that isn't completely, patients aren't really embedded. And actually, we have a new stream of work that is just starting. And it's all about supporting the development of patient organizations in countries. So again, this is about being able to link people together, because some of the issues are around the isolation that people feel, the information they get that it isn't necessarily reliable. So I think we place patients at their absolute heart. Actually, if you look at our mission statement, patients are at the heart of everything that we do. And that actually also means a different type of relationship, because we do not see patients as being in a lower hierarchy than professionals, not at all. We see everybody working in ILF as being equals, of course having different knowledge, but being valued in the same way, and connecting people. And that's really important. So people do not feel so isolated. They can be guaranteed of good information. They can be guided about how to get products that they need. And breaking that cycle of isolation for a patient is one of the things that we hope to be able to do. And we have a website, for instance, and we try to join people up as much as we can.
Also in the field of depression.
Oh, I'm sorry, Hans.
I wanted to address the need for more interest in compression therapy, as well as we're here working together with Medi as a company. I think we need to educate also the future doctors and nurses and therapists that are working with lymphedema patients. And it's underestimated how much value compression therapy can be for a patient. Do you agree? And that's the final
Of course, I so agree. I mean, compression is transformative. I mean, people often think, oh, well, it's just compression. It's not. It transforms your risk of having cellulitis. It can eliminate it. You see compression being used in India and cellulitis being eliminated. You can change. It changes people's lives. It changes their symptoms. And compression is very technical in a way. It's very, very clever what it does. And frankly, without compression, treatment is never going to be that effective. I mean, we have obviously very exciting developments for instance, in surgery, but compression is central. It's a really central part for every patient, I believe, at the moment.
Thank you.
That's a wonderful ending. Thank you very much, Justine, for your time. Thank you very much, Els, for your time also. And we close this interview now. Thank you very much again, and we wish you a wonderful day and a wonderful World Lymphoedema Day. Thank you.
Thank you.
That was really interesting to have this talk with Justine the other day, and it's really nice to have had the chance to ask her those questions. One big takeaway for me was that lymphedema has different forms in different countries, but actually the patients suffer the same. So that's the reason why it's so important to create this awareness and to run those shows like that we do today, because creating awareness for lymphedema is really key, I think.
We will now be going straight to the Netherlands with Natascha Plate, a physiotherapist from the Netherlands who owns her own clinic and treats mainly patients with secondary lymphedema after cancer. She has a high focus also on mobility, also on nutrition. I think she has a very holistic view on how patients should be treated. So I'm extremely excited to hear from her about the importance of exercise in combination with compression in the cases of lymphedema patients. Natascha, please.
Hi. Today I'm going to tell you something about the importance of exercise in combination with compression therapy in lymphedema. My name is Natascha. I'm a physiotherapist in the Netherlands. I'm specialized in lymphedema and oncology. And I'm also a board member of the Dutch Society of Physiotherapists for Oedema and Oncology. The content of today's session. At first, I'm going to tell you something about World Lymphoedema Day. World Lymphoedema Day is celebrating her 10 years anniversary this year. I hope this presentation will contribute to get more people be aware of lymphedema and what you can do with it with physiotherapy when you experience problems. After that, I will tell you about my practice in physiotherapy, some methods and backgrounds, and when I have time enough, I will tell you something about some practical examples and patient case. Most of the patients I see in my practice are secondary lymphedema patients. Most of the time because of they had cancer. And of course I see also some primary lymphedema and lipedema, but I think the first group is the main thing I see. I think the way we see the patients in our physiotherapy practice is a little bit different than most of the time because we have a multidisciplinary collaboration. We always see our patients as an oncology and lymphedema physiotherapist, and after that they will also visit the dietitian and occupational therapist. And that way we can see where the main problem is and we give the patient back some control about their own treatment. And I think that's very important. The treatment focus areas we see in our practice is most of the time fatigue, because that's the most common thing people complain about, even still after a few years. Why they come to their practice to get some help with that. They also can suffer from pain or because of their mobility problem, for example, in the shoulder after breast cancer. And of course, lymphedema. And other things you see are lack of condition and strength. When we treat lymphedema as a physiotherapist, we distinguish two stages. It's a little bit different treatment in the initial phase and then the maintenance phase. In the initial phase, we start with manual lymph drainage, and after that, as soon as it's a little bit stabilized, we get a compression. And we also do that in combination with some exercise and, of course, which is also very important, the self-management. In the maintenance phase, we start with the exercise. Sometimes we need to get the compression right for persons, and then we also give the self-management high priority. Points of interest during therapy and movement are environmental, for example, because you can imagine if someone's environment is not supportive, it's very hard to do the exercises, especially when it's a little bit stiff or when you experience a little bit of pain. It's very important that you have a supportive backup. Other thing, for instance, is the stage of illness. You can imagine that someone who's having stage 1 cancer making different choices than someone in stage 4. The scientific evidence we have is that strength training does not worsen lymphedema, and aerobic and strength training improve fitness and mental well-being. Compression during training is essential. Back in the old days, we didn't use it that often, but nowadays the compression is way better and we can use it. Well, unfortunately, not enough scientific research has been done on the effect of volume. But what we do know, it doesn't increase. So hopefully there will be more scientific research in the future. What we also know is that progressive strength training, which I told before, 2-3 times a week does not worsen lymphedema. So that's a very important thing. Now for the exercise recommendations. I was talking about the cardio and strength training 2-3 times a week. I think that's the most important thing. Next to that, we also give people some exercises with their own body weight, with small equipment or without equipment, so they can do their exercises everywhere, from work, at home, on a holiday. It's very functional. What we discovered for the last few years is that if you exercise in water, even with compression on, the results are getting better because people get extra compression because of the water. People feel fitter, people feel like taking back more control of their life. And most important thing, I think, is that the arm or leg feels less heavy after exercise. When we talk about load capacity, load refers to the stress that is placed on the body, especially to the musculoskeletal tissues. Load is seen in the form of training volume, as well as frequency, intensity, and time spending exercising. When we look at capacity, it's how much stress a tissue or body part can withstand before a generation snapping or breaking. These are main things to use in our training. When you look at obesity and physiotherapy, we see in our practice that most of the overweight people are men, but it's very close to each other. And when you look at severe obesity, then the women win again. Less obese people in the Netherlands than in other countries in Europe, but it's still a very important thing for our government to look for. When you want to know who's affected by the obesity, there are most of the time people with a low socioeconomical status, because it's still even cheaper to buy a bag of chips instead of some lettuce or something. Also, people quit smoking, children or of parents with overweight and with a low birth weight, they also are having a risk of high weight when they grow up. The consequences of overweight are, next to the reduced physical condition, you can also develop some diseases like cardiovascular problems or diabetes or lipedema or some types of cancer. That way you get reduced life expectancy. I think the most important thing to say is when you treat people with obese problems, you have to do the multidisciplinary approach again, because it's not enough to just get them to exercise, because that's hard enough. Even when they have some comorbidities, you have to look after. But also you want to do them their exercising every day, and if that's not possible in our practice, we also go to people at home to help them over there. But we also have to teach them about their food and about their exercise and what you can do with your energy level every day, so they will keep on going with the process of good food and good exercising. The exercises you can do, for example, are endurance training. Also, we do a lot of walking, cycling, because we're Dutch, and strength training and functional. I think that's the most important thing, to get their exercises to be functional. Because when you do that, it's more easy for them to hold on to and to keep on moving. What's very, very important also is that they're regaining some mobility experience. And when you experience that you can move better, it will be more fun to move. And I think that's the recipe to keep on moving. One of the examples for a obese person I saw in my practice is a 60-year-old woman with chronic pain complaints. And she was declared unfit for work because of her illness and receiving benefits, and was in a very difficult financial situation. She had painful knees, was fatigued, shortness of breath, and had difficulty with transfers. What I do is I gave her some instructions of her transfers and move in daily life. I made it very simple, because that's the way they can use it every day, and they can make small steps. And when you receive small steps and know what it's doing for you, you will do it again, because it will help you. Other than that, we did some education in the importance of healthy movement and exercise and to go to a dietitian, because it's not always like that, but when you experience some financial difficulties, that it's not possible for you to lose weight or something, because it doesn't have to be that difficult. And my favorite's the functional exercising, which we did with some water bottles and some resistance bands. And she has to walk up the stairs and down every 2 hours. I also have a practice example for my one of my oncology lymphedema patients. It's about a 48-year-old lady. She was an old nurse, and she had breast cancer in 21. She got treated with chemo and amputation, and is experienced severe fatigue and a limited shoulder function, and is starting a radiotherapy in 2 weeks. What we did in our practice is I started to mobilize the shoulder to stretch the pectoral muscle, and next to that I gave her some self-management advice to keep up the good work, to keep up the movement she got. And she also started with exercise therapy to fight that fatigue. And I gave her some app on her phone, which gave her some insight in how and when she was experiencing that fatigue, so she could learn from that. After the radiotherapy, we'll expand all of that and train the shoulder with some strength exercise. Self-management should be the key of our treatment. People have to be intrinsic motivated, otherwise it will not work. Just as I told, because in the environmental issues, if there is something wrong, it will not work. But when you make people enthusiastic, then they experience fun in exercise or what they are doing, and they get results by feeling much more better. It will become easier for them to self-manage their process. Thank you for your attention. If you have any questions, you can always contact me. You can see the email here below, and I'm happy to have hopefully teach you something about physiotherapy and oedema. Thank you.
Thank you, Natascha, for this very detailed look and very honest look into how patients should be treated in a lifelong mission once they have symptoms of lymphedema. It has been so interesting, in my personal view, to look at how important nutrition is. That exercise is actually incredibly beneficial for lymphedema patients. And then also, I love the point that I think we're going to hear from everybody today that we'll talk here in this session, is how important it is to see the patient as an individual and as a whole. One big topic that's also stood out for me was obesity-related lymphedema, and how you are also in your practice looking at the surroundings, the social surroundings of the patients, and how you would need to adapt your therapy to the surroundings that the patient is actually in.
Thank you, Valerie. Yeah, really exciting to listen to that. Thank you very much, Natascha. Staying at the secondary lymphedema and also combining with the exercise, we now go to the next topic, breast cancer-related lymphedema, presented by Justine Whitaker of the Northern Lymphology in England. Really nice to have you here. Hi, Justine. Please go ahead.
Hi, my name's Justine Whitaker, and I'd like to welcome you to today's seminar. And I'd like to talk to you today, if I can, about breast cancer-related lymphedema and why compression is needed. So hopefully over the next 10 minutes or so, we'll enlighten you a little bit on how we can manage this condition with a little snapshot of science in there too. So we're going to talk, really just keep it fairly simple, even though it will be backed up with evidence, what breast cancer related lymphedema actually is. So we're going to look a little bit at the anatomy and the physiology and what happens during surgery, so that you get an understanding as to what's happening after you've developed lymphedema, or patients that you're looking after are presenting with this chronic condition. So therefore, once we've understood all of that, we then leads us nicely into why compression is needed and what the options are, because it's not always in the place that you expect it to be. And then at the end, we're just going to round up everything we've chatted about, and hopefully we've given you some pearls of information so that you can go on and manage this condition a little bit more confidently in the future. So let's get cracking. So this picture here at the top, you can see shows a lot of green lines. This is the lymphatic system, and you can see that there's little dots dotted along the way. Those are the lymph nodes that are the filter stations that are cleaning the fluid the whole time as it's processing and going through the body. It starts off at the skin level, very, very tiny microscopic vessels that are intertwined in between the veins and the arteries. Because they're very small, there's lots of them. But as they go deeper down into the skin and then down into the deeper system and then transport back up towards the heart, they become bigger in size and fewer in number. A little bit like the veins, and the veins follow that same pattern too. And there's clusters of lymph nodes. They're along the vessels all along the way, but they do cluster. And you can see from this picture that they tend to cluster around the arm, elbow area. There's a big chunk of these in the armpit, which we'll refer to as the axilla. We can see there's a lot around the neck and the sternum. And of course, you can see that they're in the abdomen and in the groin as well. What we always see when we're looking at lymphatics anatomically, particularly in picture format, is that we tend to see the front. Well, I just want to reassure you that they're everywhere. They're three-dimensional right through the body, and we've an awful lot going on the back and around the spine area too. But as I've mentioned earlier, as they get fewer in number and larger in size as they get up towards the heart, I want to just draw your attention to these bottom two pictures, because ultimately the lymphatic system does drain back into the veins, which then drain back into the heart. So you'll see on the little picture that's got sort of the blue vessels that looks like a little V, that's the veins of on the right and the left side of the body. The green vessel that you can see growing up behind it, almost like a plant with some branches going off it, is the thoracic duct, and that's the largest vessel of the lymphatic system, and that's the vessel that runs up on the inside of the spine. And you can see then on that next picture where the body is painted all yellow, that 3/4 of the body, sort of the whole of the left side and the right side from the waist down, all drain into that left thoracic junction. So we have the internal jugular vein, and we also have the left subclavian vein, and you can see that little left thoracic duct just looping into that sort of bifurcation where those vessels meet, which then take you down then into the heart. And the same happens on the right side, but just for that upper right quadrant like we've just mentioned. Don't really know why that happens, it just does. Maybe it's because the heart's kind of on the left side. There's all sorts of theories out there. But it does help us when we're starting, if there's a problem, if we want to reroute, when we're doing things like lymph drainage. But we're going to be concentrating on compression today. But I need you to just have a little understanding and oversight of that anatomy. So this next slide makes a little bit more sense, because I'm going to focus a little bit more now on the lymphatics that are in the breast area. And we're talking about the front and back, and not just the breast. We've got to think about the upper limb as well, in the axilla. So that whole upper quadrant, depending on which side the cancer has been at. And in essence, there are 5 groups of nodes that we can identify in that breast area. And we've got the lateral group, the anterior group, and the posterior group. And they are responsible for draining the back, the breast, the armpit, and they're all sort of clustered together. And you can see on that middle picture that they're sort of coloured in yellow and a little bit in green to depict exactly where they are. And you can see in that little brown arrow a bit more of a description as to exactly where they drain. All of those three groups then drain into what's called the central group. And that's coloured purple on that middle picture. And then everything from the central group then goes into the apical group, which is painted blue. And so you can see as well from the previous slide that the apical group is very near that junction, that bifurcation of where the jugular and subclavian veins meet, where the lymphatic duct drains into. And then if I take you up to the next picture, that shows you in a little bit more clearly as to where that is, because you can see just on that neck area there's some yellow vessels, and that's sort of the junction area. So they're the groups of nodes. But what happens during surgery is that surgeons decide to do different levels of clearances. So that's where they're taking the lymph nodes from. And they, as you can see, there's three sort of levels. There is actually a level 4 if you look at if you include the sternum, but we're not going into that detail today. Level 1, level 2, and level 3 aren't necessarily immediately correlated to the 5 groups, because there's 5 groups and not 3. But what you can see is that level 1 is responsible for clearing the anterior, the lateral, and the posterior group. So, you pretty much is the first 3 groups. So everyone thinks of level 1 being a lesser clearance, but actually level 1 is quite an intense clearance, because it is the clearance that's happening that's draining the front, the back, the breast, the side, and the arm. So even if it's a level 1 clearance, you're still at a relatively reasonable risk of developing lymphedema. And of course, level 2 then takes us up to the central group, which, as we know, drains that the last 3 groups drain into. And level 3 is where the apical group is cleared. So that means that all those groups have been cleared. So when you get into a level 3 clearance, it's cleared 5 groups of nodes. It's not just cleared 3, as it kind of indicates from its name. So a little confusing when you get notes back that say it's been a level 3 or a level 1. But that's really what that means, and I hope that that's understandable, because that helps with the risk and deciding on what the risks of lymphedema are as well. So let's have another little further on about the types of surgery, which will then help us understand the risk. So removing an area of cancer or a tumour is just as a breast conserving surgery or lumpectomy. So in essence, the breast is pretty much intact and just part of it's being removed. The next level of surgery is where the whole breast is removed. And up until fairly recently, mastectomy, the whole removal of the breast, was the only option for patients that would develop lymphedema. We then go on to the next level as to whether lymph nodes need to be removed or not. And again, there's different levels of that too. So a sentinel node, lymph node biopsy, is where the lymph node that is feeding the tumour itself, and it might not be the one that's exactly nearest to the tumour, is identified with a dye, and then that's picked out in surgery and dissected. So you may only see 1 to 2 or 3 lymph nodes being removed. We can then have targeted axillary dissection, where it's the lymph node systems are all identified by dye, so that the surgeon takes much more care in cutting things away. Or we can just have a complete lymph node dissection where big wadges of tissue are taken away, and we then get that, we had 27 lymph nodes removed, only 17 were positive, or 3 were positive, or all negative. And that's where a lump of tissue is taken, and we don't know how many lymph nodes are in there until it goes to pathology, and they're picked out, counted, and looked at individually. You might also have surgery then, if you've had a mastectomy, to create a new breast. And again, that involves another level, because quite often we're moving tissue or or twisting muscles and other body parts around from other areas of the body, which then completely changes any drainage pathway and interferes with that normal kind of flow of lymph. So depending on the intensity of the surgery and what you've had removed does have an impact on the chances of getting lymphedema of the breast. And Cheryl Brunel over in America has published a paper recently, and we're still looking at the full clearance of mastectomy. Around about 30% will develop lymphedema. But if you're looking at lumpectomy with a sentinel node, then you've about an 8 to 10% chance of developing it. And they were looking at big numbers of breast cancer patients. It wasn't 35, it was in the thousands. But there are lots of other predisposing factors, which we're not going to go into today because we're going to get on to compression, I promise you. So where can swelling happen? Well, immediately most people think of it being in the arm or the hand. But actually, because we are doing a lot more breast conserving treatment, we're seeing a lot more ladies presenting with breast swelling. And not just breast swelling, but swelling on their trunk. So swelling on their body, front or back or down the side, can happen after mastectomy or even after lumpectomy. And they are difficult to compress of these areas, but there's so many more varieties of bras and body compressions that are out there, and there's lots of new products being developed for the market specifically for these groups of patients, because it is an increasing problem and one that's very difficult to manage. So be mindful where when you're examining a patient, or if you are a patient and you feel that your back feels different or your side feels different, please tell your healthcare professional so that you can be examined and treated appropriately. There's no point in just popping a sleeve on someone's arm if the whole of the side and the shoulder and the back is swollen. Surgical scars can be an area that can manifest with swelling as well. So scar management treatment is really important in that group of people too. So let's have a look what the science is telling us about compression. Well, not surprisingly, most of the research on compression is predominantly in the field of venous leg ulcers, mainly because of the billions of people out there that have this condition and the impact it has economically on health services globally. It's into the billions. So a lot of pressure, a lot of papers are in that field. Scientific papers that are published on compression often kind of really focus on the pressures of the products that are being used and deliver, and they're measuring these amounts. It's important that we know this, but all these products that we buy are generally tested to a very, very detailed level within the manufacturing process. But there's so many variables when you start testing it on people, because everybody's tissue type is different, and therefore that gives us a different pressure, and different materials give different pressures as well. But quite often the research is not on the effect of the compression when the patient is using it and their personal experience. And really that's what it's all about, is the end user, the person that's using it. Flat knit and elastic arm sleeves are part of a collective group of products known commonly as medical compression. And when we apply these on the worn, they deliver compression to that area of the body, and there's absolutely no doubt about it that it reduces and controls swelling. Medical compression devices don't just come in the form of arm sleeves for the upper limb. We use bandages, and we often use bandages and adjustable compression wraps to reduce the limb and get the limb down to a manageable size, get as much of that fluid out there, of that congested area. And we also can use intermittent pneumatic compression pumps as well. Compression is no doubt the main treatment for lymphedema, to get in control and maintaining it. And maintaining any reduction in the swelling is definitely best achieved with compression. And from a practical perspective, that's usually in the form of a compression garment. So let's have a look at the patient experience. There are some emerging studies coming out now, thankfully, and they're breast cancer related too, so that's great. So Karen Johansson, I feel, has dedicated most of her career to breast cancer related lymphedema, And her and her team in Sweden have done some really lovely studies about what it means to the patient. And in a previous study to the one we're just going to look at now, they showed that an early intervention of a compression arm sleeve prevented the progression of lymphedema up to 6 months. So they gave a group of ladies a class 1 arm sleeve, which is around 18 to 23 millimetres of mercury, and they wore that for 6 months, and they found that there was no progression of the disorder. So that's great. But what happens after that 6 months? So this more recent study reveals that the results from 6 months to 12 months, where they looked at the intervention at 6, 12 and 9 and 12 months follow-up, concluded that a compression arm sleeve, again the class 1, may be applied immediately after early diagnosis of lymphedema to prevent the progression and to avoid mild arm lymphedema becoming chronic. I think the key thing here is that once lymphedema shows its face, even in the smallest amount, it's evidence that there's inflammation going on. Lymphedema is an inflammatory condition, and when inflammation is around in the tissues, it's asking more fluid to come because it's full of nutrients, it's full of the right cells to manage that invasion, if you like, of that particular area of the tissue. So if we can control the inflammation, then we can control the swelling. And I think this is exactly what's happened in Karen and her team's study. So wearing a compression garment is not without its challenges, and particularly when exposed to heat. So there's 2 different types of exposure to heat. There's direct heat, as in going into a very hot sauna or a hot water bottle, or there's environmental heat, like living in a hot climate. Or as most of us in Europe, or the northern part of Europe, and particularly in the UK, we don't experience hot temperatures very often. So we go on holiday, we jump on a plane, or we jump in our cars and we drive to the sun and we drive to the heat. And we fly to that area of warmth where we're not really used to, and bang, we have problems with our lymphedema, particularly when we're wearing compression. And that's due to the heat itself causing vasodilation, and the whole body vasodilating, not just the lymphedema component, but also the putting on and off of the garments is tricky because of if there's any humidity, you're getting sweating and wet skin, and it's sticking. It's hard and it's uncomfortable. What the team in Australia have looked at is some work. I know Susan Witt is doing her PhD currently on the climate and lymphedema, and she's written a paper that reported from a number of patients that papers that have been published that hospital admissions due to cellulitis, in lymphedema-related cellulitis, definitely increased during the warmer weather. Infections like heat and they like warm weather, so they do tend to happen more readily and will progress and present quicker because of the heat. But what they also found there was that people, not surprisingly, with lymphedema experienced issues when tolerating the compression in heat. So they then went and did a study very recently, it's just been published at the end of last year, where they've questionnaire lots of patients and healthcare professionals and asked them exactly how they feel about the heat and what they do to manage their lymphedema. And quite interestingly, a huge number of the patients that they interviewed stated that despite the heat, they felt as though their body was craving extra compression. And as a result of this, they would often add extra compression if their swelling increased. So despite it being something that makes you want to take your lymphedema, the lymphedema and the heat make you want to take your compression off, in reality, patients found that putting more compression on actually made their situation a lot more comfortable. And when you're doing that, then you are, in theory, going to be lessening your kind of need to get your infection under control. So how do we support patients who need compression? Well, the healthcare professional needs to help patients accept what we can do to help them, and it's got to be evidence-based. And the patient should expect from us that the professional is educated and trained in choosing, measuring and fitting of compression at a proficient, confident level, so that they can teach the patient how to apply, wear and adjust the compression themselves. Provide information on what the compression is best for, which activity and at what time of night and day. We don't wear the same outfits for everything that we do. We change our clothes, so therefore should have access to different compression and types of compression to match our activities and time of day. Be available for the patient and support them when wearing compression, in particularly during physical function, social and leisure time, household chores, when they're feeling uncomfortable or have pain and have got any psychological conflicts going on as a result. The patient will then hopefully accept what we can do to help them. If they find it comfortable when they're wearing it, it's all right, the science saying we should be delivering this amount of pressure. If the patient cannot tolerate it or it's uncomfortable, they will not wear their garments, therefore it's not doing anything. So comfort has to be key in the delivery of the right compression. We would like them, if possible, to tolerate it for as much of the 24/7 regime. This is a chronic lifelong condition. Encourage them to attend the follow-up appointments and manage their own self-care regime, of course with our support. And hopefully they'll feel confident in how it looks and how it makes them feel and look too. So to conclude, we've come to the end now. I know it was a whistle-stop tour, but really, if we can understand what's going on underneath the skin and what could happen if not monitored and managed, we know it will lead to our symptoms worsening. It is a progressive disease, as lymphedema, so we don't want it to progress, and managing it with compression definitely is something that's achievable. The management, other than the specific breast cancer surgery that we've talked about in this presentation, absolutely everything else we've talked about is not just for breast cancer, it's for other types of lymphedema as well, from other types of cancers and also for primary lymphedema. And it's not, breast cancer related lymphedema is not just confined to the arm. Remember to look at the trunk, the front and the back of the patient. Monitoring and managing and moving helps to prevent the long-term risk of other problems like frozen shoulders and cording. So compression and health of the tissues is really vital. Compression is scientifically proven to maintain edema size and prevent it worsening. Controlling inflammation controls the swelling. And ensuring that healthcare professional is competent in compression management, selection, and is able to offer choices to match the lifestyle of each of the patients. And very finally, managing the chronic condition of lymphedema is multifaceted, but compression is vital once manifest, even in the early stages, in stopping the progression and reducing the risk of other complications such as cellulitis and hospital admission. So I hope that's been a useful little whistle-stop tour for you, and I'd like to thank you for your time and just encourage you to keep using compression and keep managing this chronic condition. Thank you.
Justine, really good to have you here. You always are able to bring medical knowledge together with practical knowledge. And this is something which I really took as a key takeaway, yes, that it doesn't really take only one person. It takes a multidisciplinary approach of people who are working together with the patient and have a daily contact. So mainly a synchronized approach really brings the true, let's say, treatment efficacy out of the patient and to the patient. Mm-hmm. And this is my key takeaway. Thank you very much, Justine.
So, Justine, you also talked about a very important point to me, which is early intervention and that more research is needed within this field. So this really brings us now to our next topic. It is going to be presented by my colleague, Dr. Philipp Amm, and he will be talking about prophylactic compression sleeves for prevention of breast cancer-related arm lymphedema. Hello, Philipp. Nice to have you here with us.
So thank you, Valerie, and thank you, Nico, for your introduction. And now it's my time to tell you something about the prophylactic compression sleeves for prevention of breast cancer-related arm lymphedema. And first of all, I want to show you something about the epidemiology of breast cancer-related arm lymphedema. So as you see, You have in 2022, 2.3 million women worldwide diagnosed with breast cancer, and 1 in 5 patients experiences unilateral breast cancer-related arm lymphedema after anti-cancer treatment. So it's a very, very high number of patients who receive breast cancer-related arm lymphedema. And there are different risk factors to develop such a lymphedema. First of all, axillary lymph node dissection. Second, the use of post-operative radiotherapy. The relative within arm volume increase 1 month after the surgery. The greater number of lymph nodes that are dissected. And last but not least, the high body mass index. And so, depending on these risk factors, some patients should be treated firstly. Patients who are diagnosed with obesity, which were in 2022, 890 million adults worldwide. And obesity is when you have a BMI from more than 30 kilograms per square meter. Second is when 15 or more axillary lymph nodes have been dissected. So the whole human body has around 400 to 700 lymph nodes overall, and axillary lymph nodes per side are about 20 to 30. And last but not least, patients who received axillary radiotherapy should also be treated first. Okay, let's take a look at the axillary lymph node dissection. And there you have 3 levels for the drainage of lymph fluid from the breast tissue. The first is level 1 lower axillar at the lateral edge of the pectoralis minor muscle. Level 2 is in the middle axilla between the medial and the lateral margin of the small pectoralis muscle. And level 3, the last station of the lymph fluid drainage from the breast, is the apical and cranial axilla, and medial and cranial of the medial margin of the pectoralis minor muscle. Let's also have a look at the radiotherapy. As you can see in the picture on the right side, there's radiotherapy on the breast tissue. And usually radiotherapy is high energy that leads to DNA double-strand breaks and the death, so-called apoptosis of the cells. And usually when you plan the radiation, the goal is the optimal dose-response relationship with the greatest possible protection of the healthy tissue and, of course, the destruction of the tissue that is affected with cancer. And when we are now talking about the axillary lymph nodes, they can be affected by the cancer, so they have to be eradicated. And even non-affected lymph nodes can be damaged just because the healthy tissue is also affected when you do irradiation, especially in the breast tissue. There is not much subcutaneous fatty tissue, and so a lot of the lymph nodes there can be affected by the radiation, although they are not affected by the cancer. Okay, let's have a look at these recommendations regarding the use of compression sleeves. Prophylactic compression sleeves should be offered as an option to patients at risk at breast cancer-related arm lymphedema, and they should be offered from the first day after the surgery to 3 months after the completion of the adjuvant treatments, and they should be used daily at least 8 hours a day. So this is very important when you use the compression sleeves. And here you can see the use of compression sleeves has a lot of advantages. They are relatively low cost, they are associated with minimal risk, and they are readily available. So the use of compression sleeves proves to be both a medically useful and a cost-efficient therapy, maximizing the benefit of patients at risk of breast cancer-related arm lymphedema. Now, I want to take you to a little excursus to a publication that has been published in 2022 in India from Paranamandan, which is called Prophylactic Use of Compression Sleeves Reduces the Incidence of Arm Swelling in Women at High Risk of Breast Cancer-Related Arm Lymphedema. So let's take a little look at how the study is designed. So you have the inclusion and the exclusion criteria. So inclusion criteria are that the patients needed to be older than 18 years old. They had surgery after unilateral breast cancer, and they had a dissection of the axillary lymph nodes, and excluded when there have been postoperative arm swelling, and when they were not able to wear compression sleeves and they were not able to complete the questionnaires. So the study was designed with an intervention group and a control group, and the intervention group got the compression sleeves for each arm. In this case, it was a Sigvaris arm sleeve with a pressure of 20 to 25 millimeters of mercury. And as I said some slides earlier, the sleeves were worn from the first postoperative day until 3 months after completion of the adjuvant therapy, and at least 8 hours a day. And of course, there were also introduction for donning and doffing and how to clean and wash the stockings. And the control group got education about skin care, for example, and they got shoulder exercises and received additional information material, but they didn't receive the compression sleeves. And now let's take a look at the Sigvaris arm sleeve on the left picture, but we from Medi also have an arm sleeve in our product portfolio. So this is called the Medivein Harmony arm sleeve, which can also be used to the prevention of breast cancer-related arm lymphedema, and you see our Medivein Harmony on the right picture here. Okay, what were the results of the study published in 2022? There have been 301 patients in the analysis, and the primary endpoint was the incidence of arm swelling in the first year. And here you can see the control group. 52% of the patients had arm swelling in the first year. And in the compression group, where the arm sleeve was used, only 42% had an arm swelling during the first year postoperatively. And this is a p-value of 0.004, so a statistically significant difference between the two groups. So we can conclude primary endpoint, significantly lower incidence of arm swelling in the first year, and it was assessed by a bioimpedance. And then we have the secondary endpoints, which are more quality of life endpoints, and there have not been any significant differences between the treatment groups. And of course, you could say now, oh, okay, not a positive aspect, but it's also not a negative aspect. So the wearing the stocking had no negative output on the quality of life of the patients. And of course, you can say these patients are worried about cancer, about their future, and so it is not possible to improve their daily quality of life with just the stockings. But it was more important to show that the stocking had no negative influence in their daily life. Okay, let's have a conclusion of the whole study. And for women at high risk at breast cancer-related arm lymphedema, the prophylactic use of compression sleeves, in addition to the usual care, reduced and delayed the incidence of arm swelling compared with the control group. And as I said the slide before, there did not appear any negative effects on the women's self-reported general health, physical functioning, and arm or breast symptoms. Thank you very much for listening to me, and I hope you all enjoyed the presentation.
Thank you, Philipp, for doing that presentation for us. you actually touched a very important topic that is very dear to me, that is about prevention. We know that specifically in secondary lymphedema, a lot of times the communications of risk with the patient is not often very open, or the information is not wholly given to the patient. So I think talking about this more, communicating about this more is very important. Specifically when we talk about patients after breast cancer, if they've already had a long road of treatment behind them, that they now perhaps could prevent something worse from happening. As we saw in the study, I think that there was a whole group of people that they applied it to. Can you go a little bit more into these blind spots of patients that we would have?
Yes, I think you're completely right. The important thing is the prevention. We all know that compression reduces edema, but in this case, in this publication, it's the first time that you see the risk of breast cancer-related arm lymphedema before it is really a lymphedema, just after the surgery and with the adjuvant treatments. This is the point where you can already use compression sleeves, so just as a preventive measure. And I think this is very important, as you said, to communicate. Now we have the results, we have very positive results, we have statistically significant lower incidence of the swelling of the arm in the first year after the surgery.
Yeah.
But the patients and also the physicians need to know that. Yeah, you know, the publication is now 3 years old, and it is now important to communicate this and to say, okay, you can use compression from the first day after the surgery. And this is what the publication really shows, that this is a benefit for the patient. Yeah, and it has no really risk factors to use compression sleeves 8 hours a day. So, and the patients can really benefit from that.
That is a really important point about perhaps negative things coming from that. Because I believe a lot of people, when they think about compression, specifically lymphedema, related to lymphedema, they think about a very strong compression, right? But in this case, as we're using it in preventive measure, can you talk a little bit about what type of compression it is that should be used in these patients?
Exactly what you say. So we used, or the publication used sleeves which has very low pressure, so 20 to 25 millimeters of mercury is a very low pressure. So it is not too heavy for the patients to wear that. And as we also saw in the secondary endpoints, there have not been any negative consequence for the patients. Of course, you cannot say a patient with breast cancer who suffers a lot of treatment, who is worried about the future, who doesn't know, does it come back, the cancer, and how is my life going for the next years or whatever. You cannot give them sleeves and everything is better and they say, oh, my life is so much better. But it's also the other way around, as I mentioned during my presentation. It is not a negative effect for them. So their quality of life was the same with the stockings or with the sleeves. And this is very important. And as you said, the pressure was not too high, so it's good for their daily life. They can use it and they have not any negative consequence.
What I remember from the talk just before you, the talk of Justine Whitaker, she also talked about the importance of perhaps feeling secure, and that a lot of the patient that she treats, compression actually is a little bit of a safety net for them. So the use of compression, in her case, a lot of patients already have symptoms of lymphedema, but also in a preventive measure to do that. The feeling of compression on these arms, specifically after operation, gives a little bit of a secure feeling that so also for their mindset, they can do something. I think mindset, right?
I thought on the same thing as you mentioned now, the mindset. You are, when you feel sick, and you know you can do something.
Yes,
so
exactly.
You have a treatment you can do by yourself. Then it makes you feel like you have a control of something.
Empowered again.
You can empower. And this is very important for these patients, I think, especially with very heavy things like cancer or, this is very hard also on the mental side. And of course, surgery and the adjuvant treatment, chemotherapy and something. But you can do something when you use the compression sleeves. And this is something that gives them some stability, some empowerment, some, also courage and a good feeling for the future. So they can do something to reduce possible risks. And I think this is for the patient also very important.
I think I love the word that you used, courage, because this is also something that I think we, and as well as the scientific community, we need to take. We need to have courage to process, to continue these processes, to put more emphasis on these possible patient, not just the patient that we have, but also the possibility or the risk of creating those patients in some cases, sadly. So this is where I love also our presentation that we had in the beginning together with the ILF. I think we have a very good partner where we can also push this communication on a global level, and we can see possibly results also in the preventive situation for these patients.
Absolutely. And as you said, the best way to cure any patients is that in this case, the lymphedema doesn't appear. So you do not have to treat the lymphedema if it doesn't appear. So if you can do a prevention measure, this is the best way to treat the patients. And of course, you need to communicate that, not just in this case, but on the whole world. And the more the patients know, the more the physicians know, the more courage they get. And I think this is the best way to help these patients. And this is what we all want.
Exactly. Thank you so much again for being here with us for this open conversation. I could have continued with that conversation for a long period of time.
Me too.
Next time. We will do that next time again.
I'm looking forward to it.
So see you soon.
Valerie,
bye, Philipp.
You.
Great conversation. Thank you, Philipp. Thanks, Valerie. It seems to be like prevention seems to be like brushing your teeth every morning. And this is something which I think we have to bring to the community. Also through the ILF, which we heard this morning from Justine. I think we're on the right track.
I hope so, yes. We are doing everything to be on that right track.
Exactly. All right, so now we go to the next presentation. We have Kathleen Heroes from Belgium. She is presenting the compression for primary lymphedema on patients. What is the right compression? I think that's very important to understand because we have different lymphedema types which we need to address, and every lymphedema has a different need to be treated in the right way. So, Kathleen, the show is yours.
Hi everyone, my name is Kathleen. I'm a physiotherapist and also one of the researchers in Belgium. And I'm really interested in compression lymphedema patients. So therefore, thank you, Medi, for letting me present the topic, the right compression for patients with primary lymphedema. What is primary lymphedema? Well, it's a problem in structure or functioning of the lymphatic system, but it's a very heterogeneous group. It's presumed to be genetic, although not for every form of primary lymphedema a gene is known. Therefore, they made this gene classification algorithm. In this way, we hope we get to more known about different types of primary lymphedema and the genes that causes it. It also has a more classification system according to the phenotypes. But if we look at location, then we see that lower limbs are most frequently involved. That doesn't mean it cannot be present at the genital region or the trunk, for example, but I will mainly focus on lower limbs in the presentation. You have really specific forms of primary lymphedema, which were also in classification system, like Milroy disease. And you see at the picture, the feet are really swollen, and also on lymphoscintigraphy, they saw that there was more residual activity at the feet. That's really interesting for the treatment later on. Also for lymphedema, the stichiasis syndrome, they found something on imaging techniques, and there were more problems in fluid uptake by initial lymphatics when there was more gravitational stress on the system. So it's interesting that patients with this syndrome, that when they sit down, probably they will have more problems with lymphedema. These things are also important to consider for the treatment afterwards. As you might know, complete decongestive therapy is the #1 treatment for patients with lymphedema. It consists of an intensive phase where you want to reduce the volume as much as possible. But we also want to improve the quality of life, of course. And the main component for volume reductions are the multilayer bandages. After the multilayer bandaging and when the volume is reduced as much as possible, then we go to the maintenance phase where we want to maintain this volume reduction, also want to improve the quality of life further on. And their multilayer bandages are replaced by the compression garments. But of course, other components like skincare, exercises, lymph drainage where needed, and self-management and weight control are still important. But today I'm going to talk mainly about compression. When we look to studies in primary lymphedema, it's really difficult to find a lot of them about the effect of multilayer bandages. There are some retrospective studies, though, who look at, who applied the bandages and what was the effect. And there they saw in children less than 8 years old in primary unilateral lower limb lymphedema, there was more excessive volume reduction in those who applied multilayer bandages besides, for example, compression garments or other treatment components of complete decongestive therapy. Also, another study who performed 2 to 3 layer bandaging over foam in patients less than 8 years old with primary lower limb lymphedema, they saw a significant volume reduction after 5 to 11 days. It's also important to know, can we just translate studies that are performed in secondary lymphedema to patients with primary lymphedema? Well, it's a bit questionable. There was a prospective single-blind study where short stretch bandages were performed in patients with primary and secondary lymphedema, and there was more improvement in lymphedema-specific quality of life in secondary lymphedema compared to the primary lymphedema. The volume reduction, though, was the same in both groups and was significant in both groups. However, there was another study, a retrospective study, that looked at self-bandaging at home during 4 weeks. And there they saw there was actually a better volume reduction in secondary lower limb lymphedema than in primary lower lymphedema. It was about a percentage excessive extremity volume. It was in both groups significant, though, but again, more in secondary than in primary lymphedema. Another interesting study, it was a retrospective study, also wanted to take a look, in which patient do we expect a larger volume reduction in primary unilateral lower limb lymphedema? And they saw a larger volume reduction was associated with being older, having a BMI above 40, having a history of cellulitis or erysipelas, or having a lower initial volume. So not many studies are performed about multilayer bandages in primary lymphedema, but actually it's the same for the compression garments, because it's ethically not easy to perform a study where you give one group compression garments and the other you just give no compression. Although there was one recent randomized controlled trial in patients with chronic edema at the legs. So could be that there was some primary lymphedema as well, but yeah, it's not sure, it's not reported. But still, it's very interesting to see, because one group received compression garments and education about the prevention of cellulitis, and the other group just received education. And very interestingly, they had to end the trial earlier on. This because there was a big difference in the outcomes, that there were way more recurrence of cellulitis in the control group compared to the compression group. A secondary outcome was also the volume, and they also saw that there was a decrease of volume in the compression group, but there was an increase in the volume in the control group. Quality of life was the same, though. But I think we can say that compression was really important for chronic edema at the legs. So besides multilayer bandages and compression garment, there are also other forms of compression that are applied in patients with lymphedema, like intermittent pneumatic compression. A systematic review of a couple of years ago, they conclude there was low quality studies about this, but not really high quality. Also, they were often performed in upper limb lymphedema, which is often the case in a lot of topics. And there they also saw an evolution that there are more multi-chamber sleeves nowadays, that more lower pressures are applied, and also shorter treatment times. If they look at the applied dosage that were used in the studies in lower limb lymphedema, they saw it was between 60 and 120 millimeter mercury, which is still a big range. But this year, also another study, an experimental study, appears about intermittent pneumatic compression in primary lower limb lymphedema and in controls that matched according to age, gender, and ethnicity. All these people had to do the intermittent pneumatic compression during 50 minutes at 60 millimeter mercury in a 4-chamber sleeve. And they were measured at both sides, at the treated site and the non-treated site. And what they saw, there was a decrease in circumference, but also at the non-treated leg in both groups. So probably the supine position also has its effect. They also saw an increase at the bioimpedance measurements at the non-treated whole leg. And hypothesis could be that, maybe we should apply the intermittent pneumatic compression always on both sides, just to be sure that it's not getting to the other side. They also saw in patients with primary lower limb lymphedema, there were some significant effects, but mainly at the leg and not at the foot. So again, this foot region remains a problem in a lot of things. Another form of compression are the adjustable reps. It's maybe a more recent development. So not many studies are performed either. There are some case studies, but there were only pictures in the paper, which were really nice to see. There was a really nice effect, but it was only in 7 patients, and it's more difficult to have like a firm conclusion. Another study was more prospective multicenter observational study, but in chronic edema at the lower limb. So we don't know how many patients had primary lymphedema, but again, maybe it already gives an indication. And they were followed up for 6 weeks while they have to wear the adjustable reps during the day. There were kind of a lot of dropouts, but it was a good effect on that they had a good volume reduction, also improvement in the lymphedema-specific quality of life. They were overall satisfied, but if there was some dissatisfaction, apnea, interesting, at the foot it was again a problem. But okay, it was fairly easy to put it on, and some patients even want to continue it afterwards. Another randomized single-blinded study compared muscle-layer bandages with adjustable reps in patients with primary and secondary lymphedema, but it didn't do a subgroup analysis. And it was performed during 3 weeks and had 1 month of follow-up. And they saw significant improvement in volume in both groups, and also at subcutaneous soft tissue. But the adjustable rep group actually only had an improvement in appearance, symptoms, and overall quality of life. So I think this adjustable reps can be a very promising thing in the future more and more. The last thing I want to mention, presentations, are the do's and don'ts in compression. I really recommend you to go to the FRCN group. It's really interesting what they mention about children with primary lymphedema and the advices that they give. They have some interesting documents over there. And some considerations that they mention are that, children, they grow fast, so they need regular replacement of the compression garments. Also, they have some small toes and feet, so it's really difficult and more complex to make these compression garments or apply bandages. And also know that with this small toes and feet, it's really easy to give high pressure, so we really have to lower it. Also, it's more difficult to decide, when we have to start, because it's a lot of implications for children. And of course, we have to adapt our smaller cuffs that we need for the intermittent pneumatic compression in children. So something more about the do's in children with primary lymphedema. We have to explain all the treatments in a child-friendly manner. There are some nice booklets on the market. Also on the FRCN website, you can find a color book for children. It's really nice. Also make it a routine and involve the children in rolling up the bandages, for example, or let them bandage their toy or their family member, and make compression fun and fashionable. I think the industry already plays a nice part in this, so keep continue it. And also we need to connect them with other families with children with lymphedema. We recently had a day for primary lymphedema patients. It was really nice, but I know there are other countries who have like this whole summer camp, which is really great. I hope we can continue that. But of course, also think about other networks, social networks like school, recreational activities that can be involved. What we shouldn't do is put additional pressure on the child and show some understanding. But it doesn't mean that we can just let the lymphedema progress. So they really need a good adapted compression. So it leaves me with the take-home messages. So there are different types of compression that all play an important role in a primary lymphedema. Although nowadays we put a lot of conclusions based on studies in secondary lymphedema, and we really need more studies in primary lymphedema to know what would be the right compression for them. Because we also see that studies that were performed in both groups, that it was sometimes less effect in primary lymphedema and secondary lymphedema. It's a very heterogeneous group, and we should adapt it to the more specific diagnosis and to the child that has this primary lymphedema. So I hope this was really inspiring for you to set up some new studies, to involve more products. But thank you for your attention, and have a nice World Lymphoedema Day. Bye.
Thank you, Anne-Kathleen. That was such a wonderful presentation. I specifically loved the topic when you talked about the right diagnosis for the patients. Specifically in lymphedema patients, I often feel that the diagnosis might not have been correct, and therefore also the treatment for this patient might not have been as individual as it should be. So it is so important to talk about this, to communicate that there are different reasons for a primary lymphedema, and that may also change the treatment plan for that specific patient. And above all, what we want for these patients, specifically when we talk about younger patients, is that we create a very good quality of life for both them, but as well for their surrounding family members.
Thank you very, very much, Valerie. Thank you very much, Anne-Kathleen. Speaking of quality of life, this is a good point now to make a break, buy a break, and we will be back soon.
Ich bin Caroline Sprott, alias die Powersprotte.
Mi nombre es Esther Beltrán.
My name is Nicole Facio.
My name is Dominique Rogers.
Hi, ich bin Ilka, ich bin 29 Jahre alt und ich habe mit 18 Jahren eine Thrombose bekommen.
I'm a full-time firefighter and I have lymphedema.
I have primary lymphedema from birth.
Als ich meine Lipödem-Diagnose bekam, bin ich wirklich in ein großes Loch gefallen. Aber durch die Kompression und diese modische Umsetzung davon habe ich das Gefühl gehabt, viel stärker zu werden, als ich vorher war.
A raíz de diagnosticarme el cáncer de mama, mi vida cambió por completo. El ave fénix resurge de la ceniza y eso fue lo que me ocurrió a mí. Es como un escape, una explosión de color en mi vida.
Ja, ich habe Thrombose, aber ich kann damit sehr gut leben und ich kann damit auch viele Dinge weiter erleben.
The end result is going to be, you'll be happy for where you are present.
I call them my best friends. I call them my second skin. I call them my lifeline. And I truly live that. It's such an integral part of the management of lymphedema.
There's a saying that once you look good, you feel good, and everything else follows.
Welcome back from the break, everybody. I hope you had the chance to grab a fresh coffee. Now we go to the next topic. It's Ed Hendrickx from the Netherlands. He will talk about the self-management and, of course, how important it is that the patient is actually treating himself or herself to have a good outcome of the treatment.
Okay. So hello, Ed, to you.
My name is Ed Hendrickx. I'm a physical therapist and researcher in the Center of Expertise for Lymphoprofessional Medicine in the Netherlands. I'm proud to be invited by Medi to present to you about self-management and tailored support as key factors for the future of lymphedema patients. I have no relevant financial relationships to disclose. I want to start with underlining the challenges we are facing in nowadays healthcare system. An important challenge is the enormous rise of healthcare costs, especially compared to the money spent on education, on culture, climate and defense. The second challenge is about the increasing number of staff we need to treat the increasing number of patients, while the availability of the staff is decreasing in the upcoming decades. And self-management is one of the solutions. Self-management can be described as a strategy to challenge the patients to become independent of their healthcare professional and to be prepared to explore their own possibilities. This definition, I really like it because it appeals to the healthcare professional to change the way they look at their patients. They include their patients in their daily care. The second definition focuses more on the patients. Patients who have to take responsibility to set goals and to participate in an active way in making choices and decisions. Self-management is completely in line with the new concept of health as proposed by Huber in 2011. She moves away from the old definition where health is described as an absence of disease, and she moves towards the new definition where health is described as the ability to adapt and to self-manage. We know that self-management is effective in many chronic diseases and has positive outcomes on the clinical aspects of the disease, on the quality of life as an important patient-reported outcome measure, and to reduce healthcare costs. We know in the lymphedema population that empowerment of people with lymphedema to care for themselves with access to supportive professional assistance has the capacity to improve outcomes from limited health resources. But we also know that to be effective, support programs must consider the individual patient's needs, their competencies and their preferences. In line with the conclusion of Lieke van Houten in her thesis in 2016, where she concludes that one size does not fit all, that there is a knowledge gap about how to support our patients in the most effective way to align with their preferences and competencies in the different stages of their disease. And it's obvious that this lack of knowledge may result in healthcare professionals offering care too much for some, too little for others, with negative outcomes for their health and cost effectiveness. A model developed at the Business University by Bloom and Stalpers, using 6 simple questions, can help us to allocate supportive care in a more effective way, to personalize care more effective, and it's usable within, let's call it, all chronic diseases, while it's a cross-disease model. The model assesses subjective health as a patient-reported outcome, besides the more medical-orientated outcomes. Subjective health is represented on a ladder, where the lowest step represents a low subjective health experience, and the highest step represents a high experienced health. 2 constructs, acceptance and control, are determinants to get higher up the ladder. Higher levels of control and acceptance create higher levels of subjective experience health. Acceptance is described as the feeling of the individual that his or her health status are fitting for him as a person, are acceptable for him as a person. And as I mentioned, you ask 3 simple questions. The scoring system is, if you fully disagree, you score 1. If you fully agree, you score 7. You sum it up, divide it by 3, and that's your final score. The questions for acceptance are: I'm at peace with my health condition. The way in which I'm functioning physically and mentally is acceptable to me, and I accept my health condition the way it is. The second construct is perceived control. It's defined as the belief of the individual that his or her health condition can be influenced or controlled by him, herself, or by others, so support. The 3 questions with the same scoring system are: I have the feeling that I have grip on my health condition. My health condition is to a great extent within my own power, and I have a lot of influence. By using this model, by creating scores about control and acceptance, you can create 4 segments of healthcare consumers, with each segment representing a specific type of individual with different needs for support. And as mentioned, higher levels of acceptance and control are related to higher levels of subjective health. The cutoff point for both acceptance and control is 5. As mentioned, you can create 4 segments. Segment 1 represents high control, high acceptance. Segment 4 represents low control, low acceptance. Segment 1, as mentioned, those with high control and high acceptance, they have a need for personalized information. They are really willing to manage their own condition, but they want to reduce uncertainty. They have a need, and as professional, you can discuss it with them, what they really need. It's not a black and white model, but in many cases, this group really benefits from high quality information, reinforcement of behavior, and e-health applications are very suitable in many cases for this group. The patients in segment 2, those with high acceptance and low control, they have a need for planning and structure. They are really willing to change, but lack the capacity to overview and realize changes. So as a professional, give education, provide practical help, plan their activities, work with reinforcement, again, perhaps with e-health. Segment 3 is about those patients with high control, so adequate knowledge, adequate skills, but they here really have a low acceptance. They have a need for emotive support. They are wasting energy. They are resistant. They are working very hard to deal with their condition, and they really benefit from peace and comfort. Programs must provide understanding and sympathy, and fellow patients and their peer support is very effective for this group. So as a professional, you could consider to work with patient groups or training groups or educational groups. Patients in segment 4, though with low control and low acceptance, they really need you as a professional in an individual treatment sessions. They have a need for perspective. They are acting passive in urge. And support them in making small steps in the direction of more acceptance and perceived control. As I mentioned, it's not a black and white model, meaning that if patient in segment 1, you do this and this. No, you will have to communicate with your patients to make shared decisions which support is most suitable. To do so, we use this template, a template which the patients fill in by themselves. They give a score for their subjective health experience for today and for the last months. They also fill in what do they need. And together you decide which kind of support you are going to offer. An example is this one, filled in by a male of 63, secondary lymphedema after prostate cancer with metastasis. Patient is in segment 3, representing low acceptance, high control, and he writes down, I need the motivation and the discipline to wear my garments, to exercise more, and I really need success. Fellow patients with their peer support was very effective for this patient. My take-home messages. Self-management is important but challenging. Personalized care is crucial. Patient segmentation using the SHE model with 6 simple questions can provide the basis for the allocation of intervention and supportive care. But ongoing evaluation and communications, shared decisions are essential. Thank you for your attention.
Thank you, Ed, for that wonderful presentation. I specifically love how you showed how you do it in your practice, how you do it with your patient. I love the image of acceptance and control and how you can calculate this to really specifically help your patient and how to adapt that to this specific patient's needs, because that is just it. Just as you said, self-management is not enough. It needs to be taught in a controlled environment. It needs to be with help and support of the people around them, as well as the healthcare professional in charge, to really achieve the empowerment that we want to see in the patients. So thank you, Ed, for this. So speaking of empowerment, I am extremely happy to welcome somebody here live with us who I will be able to sit down now and have an interview with to really talk about his personal experience, his personal struggles as well. Please welcome with me, Dominique Rogers. Hello, Dominique.
Hello,
so
Valerie.
nice to have you here with us.
Nice
I'm so
to meet
happy you came.
I'm so happy to be here.
It was a long travel, right?
It was a long travel, yes.
Where are you coming from again? Please
I'm
tell
from
us.
Connecticut, United States.
So it was over 10-hour flight at least, right?
Something like that, yeah. I try to not to remember, but it was a long
Just
flight.
ignoring the flight part.
Yeah.
Here has been fun.
Yeah, it's been lovely. I love it. I love it. People are great. Everyone's welcoming, professional, respectful.
For us, it was amazing having you here the last week already, right? We saw us the first time already on Tuesday.
Yes.
And you've been here now for the whole week already. Doing what? Can you share a little bit, perhaps?
A little bit of sightseeing and taking a look at Medi's, lovely, beautiful, impressive headquarters that I never expected it to be like this, but very, very professional. Everyone's very lovely. Everyone says hi, and I love it here. Love it.
Yeah, we live in Franconia, so this is an area where we tend to be perhaps not known for being that friendly, but at least here within our company, we do like to say hi a lot, actually.
Yes.
So we have you here today because we would like to tell or talk a little bit about you, about your story, about your current lifestyle, to showcase a little bit somebody who has grown up with primary lymphedema, right?
Mm.
So could you tell us a little bit about how that was for you? When did you get your first diagnosis? How was that process? Were there perhaps any challenges with that diagnosis part?
Okay. So I got my first diagnosis back in 2005.
Mm-hmm.
And the way it happened was I was playing basketball and I came down wrong on my ankle and I twisted my ankle and it began to swell. So I ran to my mother and she seen it and she's like, just put some ice on it and elevate it. Kind of not thinking too much of it. It's just a
regular sprained ankle, right? Yeah.
So the next day, my whole leg was swollen. I'm not really a complainer, really. And it didn't really feel like, it wasn't pain. It was just a discomfort. And you can tell when something's swollen, the pressure. And my dad's looking at my dad's looking at my legs and he's like, that doesn't hurt? I'm like, no, because I'm just a kid at the time. And so he's looking like, no, we gotta go to the hospital. So we went to the hospital. And around that same time as well, I had caught a cellulitis infection in my leg. I was in the hospital for weeks. And at the end of that process of being in the hospital, I got diagnosed with lymphedema.
Okay. So did you, because this is really a question that we get from a lot of different countries. Of course, you're from the United States, but we have other countries where healthcare is not as accessible, perhaps. I mean, even, of course, in the States, also some areas, but we have also different countries where it is almost difficult to have access to healthcare per se, but then also specific healthcare in the case of lymphedema patients. So what was the process once you've left the hospital? Did you have an access to a therapist right away? Were you and your family educated about what this now the maintenance of your leg was going to look like? So did you have honest answers on that?
Yeah, so when they told me my diagnosis and, before that process, as a kid, I'm thinking like, okay, this can be cured. This can be something that can be fixed. But when I found out it wasn't something that could be fixed, I said I'll have it for the rest of my life. It was kind of a downer. You know, made me definitely sad and just I was really confused. You know, didn't know why this was happening to me. Just asking these questions in my own head. So, but the process to it was us getting script from a doctor to go to a lymphedema therapist. Fortunately, I live walking distance to my lymphedema therapist, and I've been walking distance to my lymphedema therapist for probably like over 10 years now.
It's still the same one?
It's still the same.
Oh, that's amazing.
So my first one, she was great. She's actually moved to a neighboring town, but same facility. And another one I have now, she's there, and I've been going to her ever since. I usually would walk there and just have treatment there, male lymph drainage, wrappings, and massage therapy, and everything like that there.
Okay, so you already said it in one sentence. You're not a complainer, so you think I can imagine the household you grew up in.
Yeah.
How was it, that diagnosis then with your lifestyle? You said you were playing basketball, you were a young kid, you were active, and I'm saying now which is completely wrong because you still are.
Yeah.
How was that? How did then having lymphedema with the lifestyle and also progressing into adulthood, how was that for you? Also mindset wise?
I think it was hard. It was hard in the beginning, just due to just the fact that I always asked why this was happening, but I didn't really ask myself like, how can I make this better until it got to a certain point. And I think just having the family that I had to inspire me to just, don't let this like knock you down. I think that was the forefront of my battle with this condition. So, and as well as a kid, I was very competitive. And even with the condition, I still wanted to be competitive. So if, my leg was swollen, okay, I'm going to make sure that, I'm going to be as strong as I can as a kid, or fast as I can as a kid, or, make plays in certain situations to, make me stand out in certain athletic abilities. So I think that's one of the
So you took it as even a more drive.
Yes, little like, you can't stop me kind of thing.
Which also is a nice translation to your t-shirt.
Okay.
You have "Let's Fight" on there, and I think it also says some slogan on your back.
Yes.
I think that's also your Instagram account, if I'm not wrong.
No, you're right.
Can you tell me a little bit about that?
Sure.
Where did that come from?
Absolutely. It's called The Process Progress. This is one of the newest shirts, Let's Fight. It's near and dear to my heart. Just one day, a few years back in 2020, laying in my bed, just thinking of all the things that I've overcame and all the obstacles that I've ran through. Just like this, wow, it was really a process to it and to get to the progress. Just just a lot of things happening in 1 year. It was probably one of the toughest years of my life. Going through that year and making it out of that year and becoming a firefighter, becoming an EMT, making this awareness brand. It was truly a blessing that I could do that. So as you can see, the arm, this is kind of like a symbol of Let's Fight, the arms, which means like, you can see the arm is swollen on one side, not on the other side. My mother, she had breast cancer.
Oh, okay.
And so on her left side of her arm, she had to have lymphedema. She had lymphedema after her surgery for breast cancer as well. And that's another story as well. That was just something I would never trade for the world. So I have that in representation of her, also the color for lymphedema. And as well, in the back, I have it on my right leg. And so it's basically specifying that lymphedema for the right side of my leg. So that's a reason why it's really near and dear to my heart.
That's incredible. And you already mentioned that, your profession, because specifically from now my German standpoint, firefighters in the US. I mean, that is an image that we have in our head, right? And that's also a profession that is really tough, I think, both mentally and also on your body to excel at. Can you tell us a little bit about more how really your day-to-day looks like?
As a firefighter?
Mm-hmm.
Well, yeah, so I can tell you about the beginning. Just when I set out to become a firefighter, and then I say when I set out, because when I set out to do something, I plan on doing it.
Mm-hmm.
I take all seriousness in it.
Mm-hmm.
And I think that my family, like, again, motivated me just to have that tunnel vision to set out and get something done. So when I became an EMT, study as hard as I can, lock myself in my room and really just hone in on the books. But for firefighting, I knew I had to run some more. And when I thought I was done, running some more. So I also push-ups and sit-ups and everything like that. Kept my body in shape, but it was a challenge that I was willing to accept. And that was for the academy, for basically getting into it. But, you know, I still had to keep up physically, but I also had to, you know, keep my mental as well up and, you know, take care of my leg most importantly, because it's just going to be times when it's going to be challenges where, you know, it's not, you know, my leg is going to be a little bit more swollen than other times, or it's going to have, you know, it's going to have to be taken care of first.
Exactly.
Yeah. So, but I got through it. And I've been there for 7 years now, and the best job in the world. I love it. There's days where I'll be, you know, walking up a flight of stairs, like 7, 8 flights of stairs, but you know, I'll do that with a smile on my face because I know where I came from and I know where I'm in now, and you know, I enjoy it.
This is, for me, really incredible to hear, because every time I go out, oftentimes in specific areas of the world, but also in areas where I would not imagine having this reaction, specifically by healthcare professionals, where, as you said as well, your mother, after mastectomy, developing a secondary lymphedema, in your case, the primary lymphedema, we still have knowledge out where they say that a person with lymphedema should not be exercising too much, and specifically not heavily. I've seen your Instagram. I will admit I did stalk a little bit. Is that that's in your case absolutely not the case, right? So it's very heavy lifting. You run as well. Can you put, like, for once, this into a back corner, this myth of lymphedema, patients with lymphedema not being able to exercise properly?
Yeah, I think that's just absolutely just not good at all. You know, it's good for your body, it's good for your heart, it's good for your mind, you know, stress reliever, you know what I mean? On top of that, you know, with lymphedema, you know, the fluid needs to keep moving, you know, fluid, you need to move that fluid. On top of that, you need to wear your compression garments. You know, I can't imagine a whole day not wearing my compression garment, because it just doesn't look good. It doesn't look good for me, and I'm so active. I'm very active, you know. And even if I'm not firefighting or in the ambulance, I'm doing something. I'm taking care of.
Not sitting still.
Yeah, I'm not sitting still. I'm taking care of my rental property. I'm shoveling. I'm doing something, you know. So I just can't imagine, you know, I can't imagine sitting still and not exercising, because you know it's so many ways that exercising has it's very therapeutic as well. Yeah.
So now you've already started mentioning the use of your stockings. So you wear flat knitted garments on your whole leg and your toes, if I'm not mistaken, right? So did you get compression stockings right from the diagnosis point? Did you go through different types of compression? What did you start, or what are you using now, but how it started?
Yeah, I've always started with the flat knit. But when I first got the compression garment, I was just like, no way, I'm not doing this every day. I'm not doing this every day. This is horrible. And you know, some kids have to learn the hard way of like, okay, yeah, you're going to wear this, or it's not going to be good, you know?
You learned it by hierarchy in the family.
Yes, I learned the hard way, you know, through pain and discomfort, and as you know, and it's like, you know, this has to be done. And I'm glad I learned that way. You know, I wouldn't have it any other way. But yeah, I have the flat knit, and it's been great. It's, you know, I couldn't see myself not wearing it day to day, walking around just like everything's okay, I wouldn't like mentally feel right, and I can feel my leg isn't right.
So this is the thing about compression, and specifically the thing about edema that I sometimes when I do education, the sentence that I use is that edema has a mind on its own and it likes to misbehave like a little child.
Yeah.
So you have days it goes a little bit, it wants to expand a little bit. Other days you are fine for a period of time. So I'm guessing you're also using bandages or wraps additionally to, as you said, take care of the leg first. So for example, knowing that at the end of the day, after a long day of having walking stairs, perhaps you need something more additional to
extra.
your
a little extra. I love how it's becoming so many different things that I can tackle my leg with, so many different options, because I'm all for trying everything.
And you can decide on your own. I think this is with self-management, one of the big tools that we have nowadays that didn't exist 20, 25 years ago, that you have options that you can, depending on the day, how you feel, you could go through and see what makes that day a little bit better.
Yes.
So that is something that I love, that we now have options.
Absolutely.
I hope we will get more in the future as well.
Yeah.
We are continuously working on it to make that happen, so that we can offer different options and giving choices to people. I think that is the most important part.
Absolutely, and I feel like the consistency as well. Just being consistent like that is not it speaks volumes.
So, is there something that you would like to other people in your position, or specifically when we talk also about kids when they get the diagnosis first, that you would want them to know, that you would like to give them a couple of tips or things what could make perhaps their transition into that new lifestyle a bit easier?
I think when I think about kids, people say I'm a firefighter and everything like that. I'm a hero and everything like that, but kids that I didn't grow up with. As a kid, I was a teenager, but I wasn't a baby or 1, 2, 3, 4 years old, and for them to be a child and have to deal with it,
at such a young age.
At such a young age, it's completely different from how I had to deal with it. On top, and I think they're the real heroes because they're fighting way more than I am. On top of that, I think breast cancer survivors. They're my hat's off to them. I can speak from experience from my mother going through what she's going through, sitting through what she had to sit through to chemo and everything like that. They're the real heroes. I applaud them, take my hat off to them. So proud of them. And I just love seeing the kids. Because I go to a camp as well, and I love seeing kids with lymphedema, playing with other kids like with their condition. But they're kids being kids. They don't have to look over their shoulders and worry about someone's watching them and curious about their legs and everything like that. Just kids being kids, and I love that. And I would love to say to them, there's the good days are going to outweigh the bad days. Put your best foot forward and just keep moving forward, and just continue to just progress in life, and you're gonna be fine.
That is really, I think even that answer, because you did quotes for the hero part, I don't think that is necessary, because even now that answer gave me exactly the meaning that this does apply exactly to you. So what I also think is important in children that we try also to facilitate with the networks that we work with is not being afraid to talk, to ask for help. I think specifically children or parents in that situation, or also then teenagers, it's very also mentally hard to go out, search out a network, go and ask somebody, could I help this? So this camp that you were referring to, I think
Watch Me.
That creates this platform as well. So I think this is also important generally for our population and our mental health.
Yes.
That ask for help, communicate what is going wrong with you, or what not even wrong, or what you are struggling with at the moment. Communication, I think, is something that is incredibly important nowadays.
Absolutely, and seek, like you said, seek help. And some people are walking around and they don't know they have lymphedema as well.
Yeah.
on top of that, and that's big as well. Just, so I've had messages like, I think my aunt has this, but she doesn't want to go. If it's not serious now, it will get serious later.
Yeah, of course, it's a progressive disease. Yeah,
and you have to take it serious.
Exactly. And then, because this is also directed to the healthcare professionals worldwide, is there something that you would our healthcare providers not providers but professionals to know from a patient's point of view? What helped you a lot, or things where you said that could be done better? What I see if I go around, it's just a call, perhaps also for action.
Yeah.
In some situations.
From my experience, it's really about trial and error with healthcare providers. Like, I think just don't be stuck on one way. Dealing with one patient, everyone's different. Everyone's lymphedema is different.
Yeah.
Everyone's condition is different. So don't be stuck on one way. You have to expand the horizon and keep looking at different things that work for different people.
Okay, so this is really also from the talks that we've now heard in the last couple of minutes, or the last hour already, I think, is multidisciplinary approach. So even if you're in the situation as a healthcare provider where you don't have an answer, go and seek out somebody who might have an answer.
Absolutely.
So it's not just networking between patients, it's also between our healthcare professionals. Go and seek out advice from others and try to come up with individual solutions for the patients.
Absolutely.
So it has been so nice having you here. Thank you so much for coming and being here with us.
Thank you for having me. I appreciate it. Hope to see you soon.
We will see each other soon again, I'm sure of it.
Thank you.
So our next topic is going to be presented by Nicolas. He is going to give us a little sneak preview into a new highlight in our flat-knitted segment. So Nicolas, back to you.
Thank you very much, Valerie and Dominic. Dominic, you're a perfect example that lymphedema doesn't have to limit your life. We heard earlier from Christine Moffatt that lymphedema doesn't know borders. It just has a different face or a different severity or comorbidity. And that's the reason why I think we as an industry, we have an obligation to bring a new product to the market. And that's the reason why we would like to give you a sneak preview about the new product. So looking into what we've done so far, we have launched a product called medi and Oncology lateral seam back in October 2023. This was the first product on the market which had the seam not like traditional flat-knit products on the back side, but actually on the lateral side, which had, of course, first of all, much better benefits for the patients because they were able to improve their daily routine, but also daily life wearing flat-knit compression stockings. So those were 520 days working back. And so far we had just phenomenal feedback, which brought us to the idea not to only have one single product in our flat-knit range with a lateral seam, but also to bring this innovation also to another product, which is called the medi 550. Now, before I go to the product, I would love to give you some feedback of the market. And we're very close to the markets and also to you. And of course, we see that patients also post things online. And the main feedback was patients really like the new heel construction, so not to have any seam on the heel. So when people were driving to the job or doing their daily routines, there was no pressure on the heel. The second point was that when they were sitting in the office or in the dinner or at lunch, the knee area was not itching. And basically, the popliteal area of the knee, as I mentioned that earlier, is much more improved. And we have put some thoughts into that product innovation because we want to improve patients' life. So looking into this innovation and to this true innovation, we really bring innovation to the market. And for some say this innovation ended in 1970s. We in 2025 have a product on the market which is able to improve patients' life. So I'd love to, before I go to that point, patients really love it. And once they wear it, they will never switch back to the traditional old fancy product, because they really see that this product has the chance to develop and to bring improvement for their lives. At Medi, we are all working towards one goal, and to bring it into the nutshell, we want to improve patients' life, but also improve the wearing comfort. And through this, those improved benefits, those upgrades in the flatnet technology, we are of course able to bring this to your market. And I would love to show you the product now, because we have it here. Thank you very much. This is a thigh-high product, thigh-high AG 550, Medivin 550. And I would love to guide you now through those innovations which we put into the product. As you can see at the first side, the product has the seam on the lateral side. Normally, the seam is going up here. This product and this innovation does not have any seam anymore on the heel area. So if you don't have any seam here, your wearing comfort is much better. Also, when you drive with your car, or when you sit, or when you walk, the wearing comfort is much better. The second upgrade which you put into the product is that if you look at the knee area, which would be here in a thigh-high product, there's no lateral seam. So it can conform to the natural curves of the patient. And basically, through this, we really improve the wearing comfort. And improving wearing comfort also has, of course, influence on the patient compliance. And the more patients wear the product, of course, the better outcome it will be. This special product now has, of course, like up here, the top band, which is available. You can choose whatever color you want, whatever top band you want. We will launch this product in April 1st in all across the world. So all dealers will have that product available. So if patients are listening right now, please contact your physicians and please contact your doctors, because once you try the product, you will never switch back to a traditional product like a flatnet with a seam on the backside. We want to encourage you that you prescribe that product to your patient, because our slogan brings it to the point. Feel the difference by wearing it, because once you try it, you will never switch back to a traditional product. Thank you.
Thank you, Nicolas, for that nice presentation. This is always something that gives me great joy, to being able to showcase this look behind the scenes of how we do things and why we do things, but specifically who we do things for.
Thank you very much, Valerie. But I would like to thank all the speakers also for today. Mm-hmm. They have done a great job to create more awareness about lymphedema. And this was the ultimate purpose. In case you want to have some more information, please click onto or scan the QR code, visit our website, or contact our Medi representative in your country to get more information. If you want to have a certificate, just scan it. You will have this QR code also faded in the last part of the stream. So thank you again, Valerie.
Thanks everybody for being here today, as you just said, but also to you listeners, because really now your job begins. Today might be Lymphedema Day, but for us, and I hope also for you, lymphedema is something that should be concerning us all year long, so every day. So please help us continuing to spread awareness, to help out our patients, to educate more our healthcare professionals, to being able to give correct and right treatment to these patients. Thank you so much.
Thank you.